I'm Laura Erskine. I am the director of our Master's in Healthcare Administration program and the director for the Center for Healthcare Management and faculty in Health Policy and Management at UCLA. And on behalf of the UCLA Center for Healthcare Management and the UCLA Fielding School of Public Health, I want to welcome you to the Paul Torrens Health Forum. This session will be recorded and will be made available on the Fielding School YouTube channel. Generally takes a week or so, and if you RSVP'd, then you'll get an email saying that it's available for you to view. I want to make sure that I thank our donors. This event was started by Paul Torrens and renamed in his name about 8 years ago, thanks to our donors. For more than 40 years, Professor Torrens guided, mentored, and advised students at our school, helping many to shape distinguished careers in public health. Creating a space for dialogue and advancing ideas among the healthcare, health management, and health policy community, both academic and practice-based, was a priority for Dr. Torrens, and for those reasons, he created this forum. So a few housekeeping notes before we begin. We encourage questions from the audience. We will take questions at the end, but we use a technology called Slido to gather our questions. So you can either go to slido.com and enter 3410793, or you can scan the QR code. And then throughout the presentation, you can type your questions in. You can look at the questions that other people have typed. You can upvote or downvote. If someone asks a question that you think is really cool, then make sure that you give that a thumbs up. And also, thanks for prioritizing Medicaid over the Dodgers tonight. Okay, they're still losing, so. Okay, so Republicans' major tax and domestic policy bill, H.R. 1, set into motion massive cuts to Medicaid that could remove millions of people from their safety net insurance coverage. The changes are estimated to slash federal Medicaid spending by nearly $150 billion over 10 years. So there are going to be significant negative impacts of this locally, statewide, throughout the country. Millions of people in Los Angeles rely on Medi-Cal, which is California's Medicaid, for essential care. And so our goal this evening is to unpack sort of what these policy changes could mean for health systems, for clinics, for all of us as people interested in healthcare and healthcare administration. And so I want to get started with an overview from our moderator, Naderah Pourat. Her bio is up here for you to read. She is faculty in health policy and management and the associate director of the UCLA Center for Health Policy Research. Naderah?
Welcome. Thank you, Laura. It is a pleasure to moderate tonight's discussion on such an important topic. I would like to make a few comments about the context for our discussion, as well as the far-reaching implications of H.R. 1. So I think it would be helpful to look back at where we have been and where we are today, to sort of think about how the current situation in terms of coverage is likely to change. And as you can see here, in terms of public coverage, which includes Medicaid, has significantly increased due to the ACA. And a lot of that gain has to do with inclusion of individuals that are considered childless adults. That's what we used to call it at the time. And so these are individuals that were not categorically eligible for Medicaid. And so this is also the population that's specifically targeted with a lot of the language of the bill. It is helpful to understand. So one of the fundamental aspects of the bill that everyone is expecting to have the greatest impact is the work requirements for these individuals that we just talked about. And it is not a surprise what is going to happen if you implement work requirements. We know what's going to happen because we have seen what happened Arkansas and another state. There were others that tried to do this under the first Trump administration. Only Arkansas actually went ahead and implemented it. And their experience showed that it was a very confusing process. The reason for the loss of coverage, which you can see in the next to last bullet of about 18%, 18,000 people, or 23% of the population that were subject to the work requirement. So that's a pretty significant impact, had to do with how this program was rolled out, including confusing and not well-supported online portal for individuals, a lack of awareness of the key details of the bill and what individuals had to do to make sure that they actually renew or provide the information that's necessary. And that experiment also shows no evidence that it would have actually led to more employment. So the other piece of the puzzle is how many people are likely to actually get impacted, or who are the ones that could potentially be working and are not already working? Because when you look at the Medicaid population, this is a national figure, you can see that the great majority are working either full-time or part-time. And the reason a lot of the others are not working is because of some of those factors that's going to be lead to exemptions. They're not exempt. They're going to be exempt from work requirements. So that leaves only a small portion of the pie. But we cannot underestimate the impact of the work requirement. It's not just going to be restricted to people who are directly targeted. It is going to also impact everybody else because of this issue of confusion and having to provide documentation. So the burden of the providing documentation and proving that you actually are doing whatever it is that you're supposed to do is not just on the enrollees. Clearly, there's an impact, there's a burden on enrollees. But another factor that's really important is what the states must do, or the counties even, what they must do in this process. The states have to do a lot of different activities. They have to set up systems that don't currently exist. They have to verify information, for example, looking at master death records and looking at whether enrollees are simultaneously on 2 different programs. The states are not necessarily equipped to do that. And when I say states, there's a lot of variation in capabilities state by state. And of course, the verification is another, the continuous verification, continuous attestation. This is not a single one time a year you could provide the documentation. And you have so many populations, whether they are experiencing homelessness, whether they have a temporary job loss or a sudden decline in their health, or any of these issues that could kick someone off because they were not able to provide documentation. The other point that's important to remember is that the Medicaid enrollment and the loss of enrollment, the impact is not just on the individuals. There are repercussions of these on providers. There are 2 examples that I've highlighted here. For example, community health centers. These health centers are required to see all patients regardless of ability to pay. They rely on limited federal funding to provide coverage to uninsured patients. And also they have expanded after the ACA. And now with the decline of the coverage, that's going to impact these institutions as well. Another example, the rural hospitals. I think if you've heard in the news, the rural hospitals are under stress, and rural hospitals also stand to lose a lot, and that could also mean more closures. And the bill has some money for infrastructure only. It is not to be used to replace the loss of funding from patients who cannot pay. Really good analysis work by, I believe, Urban Institute, where they actually looked at the impact, not just on loss of coverage, but the economic impact. And as you can see, there is likelihood of job loss and also state local tax losses because of job losses, and also federal funding losses. And this is not restricted to states that expanded Medicaid. It also, some of those factors are also going to impact the states that did not expand. So this is not just the blue states or those that expanded. Other states are going to be impacted. And of course, here you can see that California, the estimates of what is the financial impact on California. So the numbers are sobering. And then when you do have loss of funding, when you have issues, we also experienced this, if you remember, during the recession, when the state had to make some decisions, including cutting some of the optional benefits, and maybe the states have other options if they choose to use them, such as paying providers less, such as applying cost sharing or premiums to some segments of the enrollees, such as lowering eligibility thresholds. And we've already seen the state of California took one step in terms of the undocumented population, restricting how many more can enroll in that program. So I'm going to stop there and invite Stephanie to come up.
All right. Who's excited to talk about politics? No one? Okay, that's cool. I talk about it all the time, so I'm not shocked to see that. Thank you again for being here when there is a Dodgers game. Go Dodgers? No? Okay. All right. I'm trying here, guys. Give me something. Okay, so I'm going to sort of dial us back to a higher level and give a policy update from Washington. We're going to talk about the administration, Congress, some policy headwinds, the impact to California, and then my favorite, the midterm elections, which are coming up. I'm going to try not to be political, but it's political. So we'll start with the administration. I wanted to do an overview really quickly to just talk about executive orders and healthcare leadership, set the stage for where we are right now. So in this administration and what we call Trump 2.0 in the government relations space, there have been over 208 executive orders signed since January 20th, 2025. That sounds like a not that high number. Based on this chart here, you can see that it really is not a high number, but that's a single term. And it's not the first, we're not fully through the first term. We're 8 months in, 9 months in at this point. So it's a pretty high number given where we are. What that tells you is that the administration is using executive orders to do policymaking. That's not something that we see too often. It is pretty common, and I know that folks, the media and, people in LA really noted that the slew of executive orders after the inauguration was pretty high. And that's something that's normal for a new administration, no matter if they're Republican or Democrat or switching Democrat to Democrat. Typically, new folks come in and they rescind all of the executive orders from the prior administration. So I want to note that because it's really important and it's not something to freak out about when a new administration joins. You'll see that the only other person who had this high number in a single term was Trump 1.0, Trump himself, with 220 executive orders across the whole term. The other thing I want to highlight in the administration is this healthcare leadership slide. Some of these names some of these folks have zero government experience, and some of these folks have been really, really critical of government. And I think that tells you why they're in office and why they're in senior leadership positions, but it creates a real challenge for the healthcare industry and the healthcare provider industry when you have folks who really don't understand the science of healthcare leading in that space. So what are some of the healthcare priorities? I'm not going to talk about all of them, but these are the three that I chose to highlight today. Number one is gender affirming care. While not everything is political, GOP versus Dem, for this administration, there are some key political issues. One of them is gender affirming care for minors and adults, and the other one is definitely reproductive health. Price transparency is a big one. You'll see in every rulemaking item that comes out, every proposed rule, that there is some price transparency rule associated with it. And then drug prices. We've seen a lot around drug prices, the most favored nation, trying to produce drugs locally here in America. A lot of drama about drug prices. Gender affirming care probably takes up most of my time of these three items. Gender affirming care is something that doesn't exist in every state, as we all know. Not a lot of academic medical centers are still providing gender affirming care. And it's something that I think a lot of providers and patients are quite on the edge about. So you've noticed that gender affirming care is not something that the administration has been able to outlaw yet. They've tried several times, they've been sued, and so they're using both rulemaking, executive orders, and their agencies to create hurdles in the gender affirming care space. I listed some of the agencies up here. The FTC issued a request for information for folks to essentially report doctors or report procedures that they've had that they weren't happy with. It turns out that almost all of the comments were positive. They were people in support of gender affirming care, which was actually nice to see considering what's been out there the last 8 months. The DOJ has issued subpoenas to doctors that are providing gender affirming care. They've sent subpoenas for medical records directly to doctors that they know are providing the care. The HHS has set up a tip line for anybody who wants to share a tip about a doctor that might be performing gender affirming care, and then Medicare payments. So like I said, it's not just minors. In the Medicare space, Medicare is denying payments for gender affirming care surgeries. In Congress, my fave. Does anybody know who these two gentlemen are? Cool, I see some head nods. We know Mr. Johnson, Speaker Johnson. This man, I think people know a little less. That's Senator Thune. He's the majority leader in the Senate. So what's happened in Congress since January? Since January, and where are we right now? So healthcare extenders, everything expired. On March 14th of this year, you might know that we've been in a period of a continuing resolution. There were no appropriations for this past fiscal year. We're continuing to operate on funding levels from the prior fiscal year. So in March, that continuing resolution was issued and agreed upon to last through September 30th of 2025. September 30th came and went. You're supposed, yeah, no, okay. It came and went. Wake me up when September comes. Just kidding. So the CR extended several health services, telehealth extensions, hospital at home extensions, dish cut delays, community health center funding, and a number of other things. All of those things have since expired. That doesn't mean that you can't get these things. You can still access telehealth services, but it's up to the health system to determine how they're going to pay for those services. Right now, they're not being reimbursed in Medicare. Typically, commercial providers, commercial insurers will follow what Medicare is doing. In this case, nobody's taken action just yet, at least not in the California market. So folks are still able to access telehealth while the government is shut down. What the continuing resolution did not include, it didn't include long-term extension of telehealth and hospital at home. Hospital at home, I'm not going to get too far into it because California doesn't participate. The state decided not to participate in a traditional hospital at home program, but there are 38 other states that have decided to participate. So all of the folks that were at home receiving care through a telemedicine model have had to repatriate hospitals. really challenging, right? Because they're taking up beds. And then a doc fix. So doc fix is something you'll hear about in the policy space. It's a payment option for doctors to be reimbursed in Medicare. There was a 2.3% negative adjustment 2 years ago. And remember, we're still operating in a fiscal year from 2 years ago, and that wasn't included in the March package. Since March, such a weird time, right? Because we had budget reconciliation and we thought the budget was going to get done, but now we're in a government shutdown. Yeah, some of you are nodding. It's kind of a crazy time. So what happened in the One Big Beautiful Bill Act? I call it HR1. Some people call it OB3. Some people do call it One Big Beautiful Bill Act. The most important thing that I want to mention today, and that I hope you take away from all of this, is that this represents the largest cut to healthcare in United States history. But it's not a healthcare package, it's a tax package. And you have to remember that when we're talking about policy being detrimental in the healthcare space. This was not a target at healthcare. This was a way to pay for a tax cut, and healthcare was caught in the middle. The two things that we spend the most money on in the United States. Anybody? Shout it at me. Yes. Yes, defense and healthcare. Nobody was going to cut defense, so they used healthcare as a pay for the tax cut. I always say that because I think that there is a misconception that the Trump administration directly is targeting healthcare, and that's just not the case, at least not right now, except for in the few spaces that I mentioned a few slides ago. So what are some of the changes that came with the One Big Beautiful Bill Act, or HR1? Work requirements, a big deal for California. Most people are working if they are required to. The challenge is going to be in the redetermination process. Right now, folks redetermine their eligibility once a year. They're going to have to redetermine their eligibility twice per year. Hard population to find. And we're not only talking about people that are housed, we're talking about unhoused people too, who already are challenging to track down to get the redetermination process. Immigration limits was talked about a little bit, some co-pays, and then, like I said, the redeterminations. There are some big changes to state financing. You'll notice that some of these changes impact blue states directly more than they impact red states, but they're not only impacts to blue states. Some of these things are targeted at states like California, who have expanded Medicaid pretty significantly. So we have 5 provider taxes in the state of California. The provider tax prohibition limits the tax rate at which we can go up to, and then asks us to draw it back down to a certain percentage over a 5-year period. So by 2032, we'll have less money going into the Medicaid program from providers, which means that we can't draw down a full match from the federal government. So in California, we tax ourselves as providers, as hospital systems, healthcare providers, to meet the match requirement to draw down a full match from the federal government. We won't be able to do that without the provider tax threshold. So we're working very closely on that in DC. State-directed payments are another one of those taxes that offset Medicaid low rates. And we're going to have limits on state-directed payments as well as a result of HR1. So the government shutdown, the way I like to describe it is that we put politics over policy. Some of the deadlines that I think are important, Congress failed to pass a short-term continuing resolution by the September 30th deadline. It led to what we have now as the second longest government shutdown so far in US history. People always ask me, like, what's in your crystal ball? I think we'll probably get a deal before Thanksgiving. They usually use holidays as a means to make negotiating decisions. Typically that's Christmas, but I think we'll get a deal on a continuing resolution through Christmas. So for a few weeks, they'll negotiate some of the funding, pass a minibus bill, which will include the appropriations that have already gone through Congress. And then they will continue to negotiate in the new year. I think, and don't quote me, please, I think that we're probably not going to have a new budget in this calendar year, and probably won't have another one until maybe the end of next year. So what all expired on September 30th? We talked about Medicaid dish payments. So that represents about $8 billion in cuts scheduled for fiscal year 2026, unless Congress acts by the end of the year. Telehealth flexibilities, like I said, those cease to exist under Medicare right now. Acute hospital care at home waiver, that also does not exist. and then Children's Hospital GME funding. There are a few other extenders, but these are the ones that I think are most important for you to know about. Dish payments supplement the amount of money that hospitals receive for serving a high population of Medicaid patients. And what are some of the other impacts to healthcare? 41% of the workforce was furloughed. The White House told agencies to prepare for mass layoffs. As of yesterday, the White House is no longer allowed to lay off folks in that space due to the shutdown, but there are folks that are still furloughed and other folks that will not be paid after Friday. And then on the research front, Cedars-Sinai is an academic medical center, as is UCLA, USC, Stanford. So the NIH notice of awards are not going out. So we're not receiving new funding for research at this time during a shutdown, and study sessions are either delayed or postponed, which means that research is essentially, new research is not happening. So what are the policy headwinds? These are some real policy concerns that we have as a system and that generally other hospital systems probably have as well. The 340B drug pricing program, that is always going to be a concern. It's a hot topic in Congress. And again, the administration is using rulemaking to make changes to policy. That's not legal. I'm not a lawyer, but it is something that's been challenged in court over the last 8 months. Site neutral payment policies. Site neutral payment policies are these policies in Medicare that say if you get one service in a licensed hospital facility, you should be receiving the same payment at the lower cost that you would receive in a community setting for that service. The challenge is that hospitals provide really high level service, oncology services, infusions. These are not things that we can pay for at a community setting, rate, and also not something that a community setting can provide. So we're really concerned about aligning payments in Medicare. The future of academic medicine and research funding is always a concern, even in the last administration, but it's more of a concern here. We've seen huge cuts, as you know, to research institutions, and it's going to continue to be a challenge for us. Immigration enforcement and reform, something I like to mention because folks don't always connect immigration and social issues to healthcare. We have a lot of challenges in the immigration space, both on the visa side for folks that are at an academic medical center on an H-1B visa, for example, and then also in the population side. As folks continue to be not covered by healthcare anymore, by insurance, by the Medicaid program, what do you think they're doing for healthcare? They're not accessing preventative care, so they end up in our emergency departments, not just sicker, but also without insurance. So we take on the uncompensated care cost for folks that don't have insurance. And those folks are going to take up beds for much longer because they waited so long to get care because they are afraid or otherwise can't get it in a community-based setting. So what are the impacts to healthcare in California? So the state budget, I know this was talked about a little bit, but I'm just going to run through it quickly. The state had to make some decisions. So we pass our budget. It's signed by the governor by June 15th every single year. There was a reopening of the budget this year because of HR 1 being signed on July 4th. So some of the things that happened in the state budget, the state of California, decided to freeze Medi-Cal enrollment for new undocumented adults starting January 1. New undocumented adults means that if you are enrolled in the program now and are undocumented, you will maintain your coverage, but new folks enrolling in the program will not be allowed. It establishes Medi-Cal premiums at $30 per month starting in July. That initially was planned to start January 1, but got pushed 6 months in a trailer bill, so that's good news. And it reinstates the asset limit test. You might remember that there was an asset limit test that was really restrictive for folks that maybe are living on a limited income but have a paid off home in California. Pretty much any home in California is going to put you over an asset limit test, but not eligible for Medi-Cal because of that asset that they own. So I don't remember exactly what the reinstatement amount is, but they did reinstate the asset limit test, which really all means the same thing: more uncompensated care, more people that are not covered by the Medicaid program. And then the provider taxes we talked about already. So what are some of the downstream impacts? I think, increased wages are definitely something that are a challenge in healthcare. We are constantly battling with the unions about wages. California saw a healthcare minimum wage pass at the state level 2 years ago, $25 an hour for healthcare workers. Cedars-Sinai implemented immediately, absolutely engaged in that. There's a new measure at the City of Los Angeles level that is not targeted at hospitals, but would include hospitals. It's a hospitality measure proposing $30 an hour. I think the challenge is everybody needs to make more money, and we understand that there has to be a balance associated with that. LA is an expensive place to live, work, just exist. And we want to make sure that we are striking a balance with our workforce to ensure that they are both well compensated and that we can keep our doors open and maintain jobs for them. We talked about increased uncompensated care, some higher acuity patients not seeking preventative care in the community, and then more scrutiny on spending, pressure to do more with less. And I have here a list of the bottom line. Bottom line, I think, is that healthcare is under a microscope. We are already very careful in healthcare about how we act, how we spend money, what we spend money on. But we are being scrutinized at a level that we haven't ever been before. And I think folks have to be even more careful in the way that we operate health systems moving forward. Really quickly, my fave. Yeah, okay, that was enough politics. Okay, election season. So November 2026 is an election year. All 435 seats are up for election. Dems can take control with a net gain of 3 seats. That's really important just to watch. Again, not a political speech. This is just the way that politics works, cycles back and forth. 35 of the 100 Senate seats are up for election, and Dems can retake control of the Senate with 4 seats. This is my last slide. It's my favorite slide. Who lives in LA County? Lovely. Who knows who all of their representatives are? Oh, yeah. Okay, so scan this QR code. I am I'm a millennial, but I did not know how to make a QR code before this. So enjoy my QR code. If you scan this code, you can find all of your elected officials. You type in your address, it'll give you a list of every level of government. All politics is local. It's really important that if you care about policy, to care about the people that you're voting for outside of the presidency and the federal elections. Thank you, and go Dodgers. Sorry, I forgot to introduce you, Tim. Next up is Tim Murphy.
That's a tough act to follow right there. A lot of good information. There's going to be a little bit of overlap in some of the information that I prepared. So I will ad lib. Do I drive this one? Okay. Well, good to see everybody. My name is Tim Murphy. I'm the treasurer down at Sharp Healthcare in San Diego. But today I represent sort of myself as a student in the MHA program at UCLA, as well as a treasurer in the financial, coming out of a financial services industry background and recently into healthcare. So I have something of a unique perspective on this sector to share. Paul Torrens was an educator, and to be here and contribute to this conversation is such an honor because the need is great. I got into this program at UCLA because of the COVID-19 pandemic, and I was really moved by how that pandemic impacted people and populations and health, and I wanted to be a part of shaping healthier communities. And so to be here today is like a dream come true. So thank you. All right, so we'll advance. We'll start with a little quote. So, hard work. Anyone who's in here understands the value of hard work. I'm going to open with a quote. It says, "All labor that uplifts humanity has dignity and importance and should be undertaken with painstaking excellence." And that's Martin Luther King Jr. I hope that resonates with everybody. It sure resonated with me. This is a challenging time in our country, in healthcare, but there's a need, and we're committed to fixing this challenge, and pursuing that vision with excellence is critically important. I then jumped down to SHARP, my employer's mission statement there, and I won't read the entire thing, but I'll say it. SHARP Healthcare mission is to improve the health of those that we serve with a commitment to excellence in all that we do. And so that's a common theme to Martin Luther King's vision. So about SHARP, I hope everyone knows SHARP because I'm quite proud of the organization, but we are the largest by market share provider down in San Diego County. We have 4 hospitals, 4 specialty hospitals, medical clinics. We're an integrated provider. We have our own health plan, total assets a little less than $9 billion, and total revenue a little over $5 billion. Okay, so setting the context, I understand that questions have to be submitted via the code, but I might prompt the audience a little bit. And I'll come off the slide a little bit here, because I'm multiple times throughout my discussion, because I don't want to repeat too much of what's already been shared by Stephanie. So healthcare, so I'm going to take a step back even from what's on this slide. Healthcare spending in the US. So we're here to talk about HR1, the big, beautiful bill. But you have to take up, like, where are we as a country? Does anybody understand where we are in terms, so I have a finance background. I worked for JP Morgan for a time. Thank you, JP Morgan, for being here today. So does anyone have a sense of let's start with what we spend on healthcare in the US in total? You can give me an absolute value or a percentage of GDP. That's exactly right. 17 and growing up close to 20. It's on the rise. Anybody want to guess at what? So yeah, in case you couldn't hear that, this is being recorded. The answer from the audience was 17% of GDP, and it's right in there. 17 growing, 18 plus, depends on the source of reporting. What's the year-over-year increase in healthcare spending over the last 2 years? Anyone want to guess? So it's 7.8%. And, you can Google me and check this sort of stuff. This is from memory, so give me some leeway, but it's about there. It's between 7 and 8% is the year-over-year increase in healthcare spending. On a per person basis in the US, any guess of what we spend per person in the US? A big country. Any guess? That's exactly right. $15,000. $15,000 per person per year. That's what we're spending on healthcare. Boy, that's incredible. How fast is our economy growing? GDP growth. Bankers? 3.8%. Sound about right? Inflation numbers just came out. Anyone following financial news? What were the inflation numbers? Just came out. What? There you go, 3%. So we have healthcare going at 7 or 8%. We got economy growing at 3 or 4%. We have inflation at 3. So that's a challenge. That's a tough context. So last 3-4 years, 2019, pre-pandemic, would it surprise you to know, this is per a study that came out by Kaufman Hall and Associates. I have their permission to use this. They had me change the title, which Laura, their legal name reference, good folks over there, great firm, Kaufman Hall, part of the Vizient Group. Pre-pandemic, 40% of California hospitals were operating in the red. That's scary. We don't want to run our households in the red. What happens? Not good things, right? We saw some statistics on an earlier slide about the number of hospitals, especially rural hospitals, closing. But it's not sustainable. You can't run at a loss every year, right? We wouldn't run our houses that way. Even more scary. And my employer is in this sample set. 53% of hospitals in this most recently concluding fiscal year are going to run in the red in California. 53, more than half of them are running at an operating loss. That's scary stuff. To me, it's terrifying. I'm a finance leader in a healthcare organization that's working its way through this storm. So that's the context. And I can tell you that I want to read this quote, actually. This is coming out of the California Hospital Association. Hospitals throughout California and across the country are facing financial headwinds, the likes of which have never been seen before. driven by skyrocketing labor costs, pharmaceutical costs, medical equipment, and unfunded government mandates. That's seismic for us here in California. We can talk more about what that is if you're curious. More than half of California hospitals, now 53%, lose money every day that they're caring for patients. The costs of care have risen more than 30% in the last 5 years. And that's that disconnect, that delta between the rising costs of healthcare and the growth in the economy and inflation. Okay. So what does all this tell us? And so it's a tough operating environment. To me, it says we need to make some changes. We need some degree of reform. So I think the notion that we should disagree with, I certainly agree. Healthcare needs some reform. You can layer the fact that we should be the absolute healthiest country in the world. We spend more than anybody else. That 15,000, the next closest high income country is like 3,000 less per person per year. But we're pretty sick. I think all of us would agree. Those of us that work in a healthcare setting know that our people are not healthy. You know, we have high degrees of disease in our country. And unfortunately, since the pandemic, our average expected life is now declining in some places, right? And that's scary, especially given what we're spending. So, okay, so with that, HR 1, we heard it. I provided a range here coming out of Becker's, but they're suggesting between 64 billion and 128 billion of expected revenue that's been cut out with this reform over the next 10 years. That's coming out of Becker's, that point of reference. So I'm not going to get too much into, well, let me share one other statistic because it's in there. It says that healthcare costs have risen 30% in the past 5 years. At Sharp, we are closing out our first year running an operating deficit in our recent history. We've historically operated at very healthy margins, but the backing out of stimulus program dollars and the escalation of costs, and while we continue to pursue seismic compliance and investment, seismic for us is we're going to put $1.8 billion into facilities over the next 5 years. So these are big dollars. And when you work that back, you're looking at least $5 million a week going into buildings to meet, in large part, both strategic growth opportunity investments, but also seismic compliance, which are state-driven requirements. Very important, but very expensive as well. But our costs at Sharp have increased approximately 44% over the same horizon. And they've risen at a rate that's against the 30% reference in this slide. And they've at a 1.27 times the growth rate in revenue. So we have that same mismatch. And it's due to all the same reasons that were quoted on that slide. Okay, so big, beautiful bill, HR 1. I think I'll just reinforce a couple of points that I think are very relevant to everybody to keep in their mind. That a lot of the steps that were very well covered, they just do a good job of pushing people out of coverage, whether it's causing them to work or whether it is having them recertify or recredential every 6 months, which how many of us dread when we had open enrollment? We're coming into open enrollment season. It's like, oh man, I got to do that, right? Imagine doing that every 6 months. It's scary, right? And some of the folks on those programs are not, that's a really big deal. The other thing they did was the look back. If you fell out of coverage and you had to reapply, maybe after you went to the doctor, it used to be 90 days of retroactive coverage, right? Now it's 30. That's scary too. And it's just all these little nips around the perimeter that are resulting in sort of less people participating in this coverage, which means less insured population. Perhaps, yes, lower cost. We know we need reform. I shared those statistics, but at what cost to society and public health? And when we'll get into it, I'm getting a little ahead of myself. Spending volumes and utilization, the rest of the story. So that was a little bit about the context of costs, the trending costs over the last 5 years. What's the other thing that happened in COVID? We all lived through COVID. Everyone in here lived through COVID. What happened in hospitals? They were there, right? They were open and serving patients. In many cases, they were very full. But for those of us who was healthy, what did we not do? Didn't go to the doctor. Didn't go to the hospital. So what happens when you're a healthy person? Why do you go to the doctor when you're healthy? Yeah, It helps you stay healthy, right? Preventative care, diagnostic type care. So, and also people who were somewhat sick or maybe had some condition of morbidity, they also didn't go because they were scared, right? We were all scared. We didn't know what was going on in those hospitals. It was a scary place to consider going. So we had all of a sudden people stopped kind of coming into the hospitals. We're highly capitated at Sharp. What does that mean? Anybody? And the students should have that, depending on which coursework you've taken. We have a lot of patients that are where we receive a set amount of pay from an insurer per period, whether or not depending on whether or not the patient comes in and consumes care. If they consume a lot of care, we make less margin. If they consume a little care, we make more margin. So highly capitated health systems like Sharp did very well through the pandemic as less care was consumed by a lot of the insured population. But what happens when everything comes back to usual, it was already said in the last presentation, we have sicker people, right? So that's what we have. That's what we wind up with. So we have healthcare spending volumes and utilization. I'm going to read this quote, which comes out of Becker's. As the nation's population ages and healthcare sector faces a wave of workforce requirements, capacity has become a defining operational challenge. Inpatient days are rising, emergency department volumes are climbing, and discharge delays continue to disrupt patient flow. Everyone should be pretty familiar with that. But basically, it means that we're seeing more people coming into the hospital. They tend to be sicker and require more care. And so that's what happens when people don't have access to coverage. In that case, during a pandemic, but you can catch the analogy, right? If we push people out of coverage, can't go to the doctor, can't receive preventative care, the cost for the care when they eventually need it, and maybe it'll come as uncompensated care to providers, it's going to be more, right? Sharp last reporting period that we were public with was fiscal 24. We're September 30 year end. We're just closing out our audit right now. We're working on our audit, closing out our fiscal year end. We had about 600 million in unreimbursed care, just a system of our size. So when you increase deductibles, when you have folks that have less coverage, all of that means that the hospitals are going to have to absorb those costs. And you know where those stats are, 40%, now 53% of California hospitals running in the red. So that's the context. But I didn't want to end my presentation without a bit of hope. So Tim's top reasons for hope. So we're going to come back to purpose. So people living and working on purpose. I believe that a lot of people who work in healthcare, whether you're a clinician, whether you're administration, whether you're just working in the hospital, which in the US is 14.7 million people, roughly, age 16 and older. That's almost 10% of our working population, according to the US Bureau of Labor Statistics. Those people are there because they're passionate about other people. Like they're there and they work really hard. We have really good people working really hard, pursuing excellence to solve this and to try to create healthier people and communities. So, and I think that's like, don't underestimate the power of that. Like we can do an awful lot. And I think that the people in this room are going to be a big part of that, especially the students. Okay, innovation, technology, and artificial intelligence. Everything's changing, like everything. We're going to have different diagnostic care. We're going to have the opportunity to automate all sorts of manual functions, whether it was clinical note-taking at onset, whether it's very sophisticated coding. The use cases for AI, technology and innovation in healthcare are immense. And so I think we just need to hang on, innovate for the future. The model, what it looks like in a few years, will likely be quite different. And I think it could be much better. And, you know, we need reform, right? We've covered that. But if we were looking to need reform and there weren't any levers to pull, I'd be really nervous. But we have a lot of levers to pull. We can all operate more effectively and more efficiently. And so I take a lot of comfort from the opportunity for change. And so we shall persevere because we must. We have to, right? This is a business of must. And so we start with excellence. We finish with must, and that comes to you from Carvine Sabatano, who, if you know him, is an author that deals in the field of human behavior. So I'll end my comments there. Thank you. Oh, am I doing the next slide, Laura? Okay, thank you. Pardon my transition. I'm a student learning.
Hey everyone. Can you hear me okay? All right. I'm Naderah Pourat, CEO of Venice Family Clinic. I wish I wasn't talking to you about this today. This is frankly depressing, angering, and we shall overcome. We must persist because we have to, right? So a lot's been already covered that I've already by my excellent co-panelists, and Nadia and I picked a few of the same graphs because I was like, what am I going to talk to you all about? And I ended up picking a few of the same, but I might give you a different twist on it, maybe a different angle, a different perspective on it. So I was thinking, and I remember this New England Journal of Medicine article, which was published during the pandemic. I was sitting alone in my room and I saw this article buzz by and I thought, it was great because I was like, I needed to be inspired. I needed to be remotivated to what we were doing and what this was all about at a moment when I personally needed it. I don't know if others did. And it talked about the Affordable Care Act and the successes at the 10-year anniversary of the ACA. And I was just, as I was driving here, sitting in traffic on the 405, getting to this conversation today, I thought to myself, I really miss the 2010s. I'd like to send the 2020s back. I mean, we had the pandemic. We've had all these challenges that we're talking about today. I'd like the 2010s. And the reason was this. In the 2010s, we were doing what felt like really amazing things. We were expanding access. We were getting people covered. We were breaking down barriers. It felt like we were making tremendous progress as a country to get people coverage. And we know coverage is care. Care saves lives. And you can see Nadi's slide was more current than this. And I kind of looked up, I was like, who's uninsured today? And it was 26 million roughly are uninsured as of 2025. But you could see that 26 million, we even beat the ACA projections, which is tremendous. And that's because I think we built a movement of in this country. 26 million is still too many, in my opinion. For a country that is as developed, as wealthy as the United States is, the wealthiest country in the history of the universe. We don't know all of extraterrestrial life, but of this planet at least. And then I kind of pulled some stuff out of the New England Journal article because it's interesting. The Medicaid expansions and the marketplace subsidies actually ended up costing less than was projected. 128 billion in 2019 compared to the originally projected 172 billion. And it showed at the 10-year mark, and I've read some other articles, as you may have as well, of the impacts of the ACA, that there have been substantial reductions in mortality from cardiovascular causes among middle-aged adults. It has the citations. You can go find this New England Journal article if you're really interested in reading it. And that fewer people died. Coverage saves lives. As everyone's talking about today, we're going back. And I wish we weren't. Because we know these have been mentioned already, but I'll just say them again because they're worth saying again, because we got to not lose sight of these things and we have to continue to fight. And if you believe in coverage, if you believe in care, if you believe that healthcare, what we do in healthcare saves lives, there's work to be done, as others have said, in a lot of areas. But people will literally lose coverage due to paperwork burdens. They're busy living their lives. They are the group that we're talking about, by the way. And I'm going to speak as a leader of a community clinic, community health center. 80% of our patients are living at 100% of the federal poverty level or below. 97% of our patients are living at 200% of the federal poverty level or below. The Medicaid criteria, Medi-Cal criteria in California is at 138% of federal poverty level. You qualify for Medi-Cal. In real terms, these are just like, well, okay, these are wonky a little bit, but what does that mean in your pocket? What do you have? For a family of four, that's $444,000 a year. That's who we are giving tax cuts on the back of. On a family of four making less than $44,000 a year. Is that ethical? Is that who we are as a people? I hope not. That's not how I was raised. That's not what I came to believe as a son of immigrants, that was what this country was about. This country was an inclusive place, is what I was taught, what I was told. We know about the cuts on the backs of the most vulnerable of the vulnerable, the UIS population. People don't understand that we have a broken immigration system in this country. I like to read the comments section, as some of you may, online on articles. I do it because I'm a sucker for punishment, but two, I like to understand like how average folks are thinking and talking about things. And some of the comments that I read say things like, if she was undocumented for 20 years, she should have obtained legal status by now. How? There is no such process. If you entered this country as an undocumented individual, trust me, I've consulted employment attorneys left and right on this topic, because the first Trump administration, there were a lot of threats to the UIS population too. They didn't actualize most of those threats, but this time they are, obviously. And we're balancing the California budget on the back of the UIS population. Health for All, which was the name of the bill, is gone effectively. But care will be still guaranteed in the emergency department because EMTALA exists. There is a law that if you show up in the ER and you're sick, you're going to get care. Who pays for that? Tim talked about the 7 to 8% annual premium increase. There you go. You're paying for it one way or another, and it's probably going to go up to double digits and year over year. And we know delays in care will occur. Care is going to happen in the wrong setting. Care is going to be deferred. People are going to have later stage cancers diagnosed, as they have been post-pandemic, because they were deferring care. So there's a tremendous human impact that is being undertold and underestimated. I just wanted to highlight it's 8% that we're talking about that is not working due to retirement, inability, or to find work or other reason. And that's out of this survey data that was done. So out of Kaiser Family Foundation. So when we're talking about work requirements, we know that 92% of people on Medicaid today are working full-time, part-time, not working due to caregiving responsibilities, not working due to illness or disability, not working due to school or attendance, for school reasons. So it's not really a thing, guys, where it's just more bureaucracy. It's more paperwork. It's to try to put more in the way of people getting coverage and care. I was thinking, like, what perspective can I offer that might be different? And what troubles me most, and what angers me, what keeps me up at night, what keeps me working, is that it's our people. These are our neighbors. These are the people that you walk past when you leave the auditorium and you go down the street and you see someone who's struggling, who might not be as well off and as fortunate as you might have been in life. These are the people that are going to be affected. These are going to affect real humans, real people, this is someone experiencing homelessness that Dr. Coley King, who's on our street medicine team, he's our director of our street medicine services, is talking with on a park bench. We're going to have to make cuts potentially and affect our services that are offered. These are real humans that really, you got to see their faces. They're going to be the ones that don't have a card in their pocket that covers services in an appropriate setting. In primary care, we account for 4% of overall healthcare spend in this country. In community health, where we are taking care of the 10% of the population nationally. We serve about 32 million people across the country in FQHCs. We're about a network of 1,400 health centers nationally. We care for about 10% of the population. We account for 1% of healthcare spend. We're cutting care in that setting. It doesn't make sense. It's penny wise, pound foolish, or we think we're saving money, but I think we're actually going to end up costing more in the end. We do have a cost problem in this country, as others have said. This is percent of GDP. You said 17%. This is 2 years old, so 16.6. We aren't getting great value out of the spend, and there is work to be done in this area. And so it's like, what is the cost? What is the cost? Yeah, there are issues to work on, but I don't think we're going about it the right way. And as Stephanie said, it was about tax cuts, and how do you close a tax cut loophole, you do it on the backs of people that need it the most. Sorry to be a downer. But we're here to do the work. We have a network of clinics at Venice Family Clinic. We're going to persevere. We have to. We have to find a way. The economic pressures that others have been speaking about are real. We have been running a leaner and tighter operation. And in spite of that, we're managing to break even. Woo. I mean, we're doing hard work to try to float the boat. And we don't have huge reserves to fall back on. And we need to make key investments in our facilities, in our IT infrastructure. Our clinicians want AI tools to use to provide care in a better way. How are we going to do that? We're going to have to get creative, and it's going to be harder in the years to come. So I'll end on this point, and that is simply to please stay engaged. Please stay a little angry. We're going to accept some amount of this, but then we got to fight as well. If you believe in coverage, if you believe that coverage translates to care and health and well-being for people that need it the most, we got to stay committed to the work. And I'm trying to take the multi-year, multi-decade lens that this is a long arc, and hopefully, as MLK said, it will bend towards justice. So thank you so much.
Okay, I'm going to invite our panelists up on stage for the Q&A. All have a microphone, and the microphones are all.
Are the mics on?
Yes.
I was gonna join everyone else in call to action and ask everybody to speak up. Don't sit there quietly. Follow what Stephanie said, follow who you can speak to. Keep hope, but do something. So I would start us with one question. So the impact of the legislation is hard to predict, right? Since it so much depends on how the language is interpreted. It depends on how it's finally implemented. There are multiple agencies like HHS and CMS that it has to go through, and they will all have a role in interpreting the bill and providing guidance to states or other stakeholders downstream. So at a minimum, this means uncertainty in exactly what will eventually happen. So I was going to ask each of you to say, what do you see as the biggest challenges of implementing this legislation, and which aspects of the bill you consider the hardest to implement?
Yeah. All right.
You're the
first.
government affairs person.
Yeah, I am the government affairs person. I think exactly what you said is the hardest part, the uncertainty of all of it. I didn't show a timeline, but oftentimes in my slides, I show a timeline of implementation of HR1, and you'll see that not everything implements today or January 1 of next year. Things will happen over the next 5 years. Lawsuits will happen. The makeup of Congress will maybe change, probably change. Looking at a political science background would tell us that it will change and swing back to a Democratic held, at least House, maybe Senate, but at least House. So I think it's really hard to determine what our bottom line is going to look like. I think what we've tried to focus on at the health system is the creative way in which the administration is implementing policy or trying to impact policy, which is through rulemaking. So it's not through congressional action or through executive action, it's through rulemaking. And all they have to do is issue a rule, hold it open for a certain period of time for comment, and then finalize the rule. There are things in rulemaking this year in general payment rules that we've never seen before. We've never seen policy decisions being made in rulemaking the way that it is right now. And I think that's probably the most challenging thing for us. I probably lose the most sleep at night about two things. Gender affirming care is number one. I always want to be able to provide patient care to everyone that needs patient care. That is what's most important in the healthcare space. And number two is what's going to happen in rulemaking that I can't control. I can hit the halls of Congress. I can hit the Hill. I can hit the legislature in the Capitol in Sacramento. I can't do that with rulemaking. I can only comment through a comment letter and hope that they care. And if they did care, they wouldn't have proposed the rule in the first place. So, we're in this constant cycle. So I think that uncertainty has been really challenging to account for. And that's probably what I focus on more than the actual legislation itself.
I'll hit on just a point of that you were talking about around the 2-year implementation period, basically. I think two specific aspects are the work requirements and the frequent redetermination, speaking specifically about HR1. And I think by design, it has been put in place to happen over 2 years. So one would argue that, oh, that allows us time to adjust. Sure. It also allows us time to psychologically adjust and accept this as a new norm, and to also have a gradual attrition that just people are just slowly falling off of Medicaid rolls, and we kind of don't notice it again, and we don't pay attention to it. So I feel like the cynic in me would say this was by design and almost calculating to have the effects go past the next election. So the worst effects are in the out years, and we know how finance accrues over time. So I think the financial savings, if there are any, are in those way out years, and they can still claim victory on a 10-year cost savings basis that the CBO says is true or something like that. So I think the combination of those things.
All right, I'll just, I won't repeat anything of what's been shared, all of which I agree with. Being a finance person, and the finance people in the room have already heard me talk about this, I think the specific provision of HR1 that we are digesting, which it has the greatest near-term implications to us, has to do with the how Medicaid, Medi-Cal is funded here. I think hopefully some folks may have a deeper understanding of the general structure of the program, but there's we tax ourselves. So the federal government contributes to how Medi-Cal, Medicaid is funded in the state of California through this provider tax program. And there's a lot of politics and press around this right now because all the states pay into the federal government's coffers, and then the federal government pushes it out somewhat disproportionately by state. We take a large share, but we're a large economy, right? We have a lot of people. So it's all very sensitive from a political standpoint. But one of the things that was done with HR1 is that program, that provider tax program was frozen. So it can't go up. But we don't know if it was frozen under, and we call it internally in hospitals, some of us, we call it quality assurance fee, QAF is the acronym. We don't know if it was frozen on last year's settings or this year's settings. It's QAF 8 versus 9. And to my organization, the difference between those two is about $47 million. So this is serious business. And we accrued on the newer level through when that legislation passed. And then we backed off and accrued for the balance of the year at the prior level to sort of minimize our exposure. Different systems have taken different approaches to that. But like there's immediate impact to this legislation in terms of the dollars that we'll receive for the care that we've provided.
Thank you. I was wondering if I was going to ask you what keeps you up at night, but you've all talked about it. So I'm not going to repeat that question. But what would you, if you could send a message directly to policymakers about the realities that you face at your institutions, what would it be?
Mine is that hospitals will close. And I think that folks hear that and don't really recognize it as a reality, but hospitals are already closing. Olympia Medical Center closed in 2021, maybe. St. Vincent's closed just before the pandemic. Cedars-Sinai has seen over 100 new patients daily census because of the closure of just those two hospitals. We saw Naderah Hospital close in rural California, Northern California. And then the state bailed them out, but they're not operating at full capacity because they closed, lost their whole workforce, and now can't get their workforce back. So I think the reality is that without money, healthcare is going to cease to exist except for the few facilities that are able to stay open, and they won't have the capacity to serve everybody.
Folks are looking at me, so I'll respond. What keeps me up at night right now is 3I Atlas approaches its perihelion today on that's the closest distance to the sun, and that's the third interstellar object to pass through our solar system. So I'm very curious to see how that pans out. That's what's keeping me up awake at night at the moment. Most of you who are into that sort of thing. I think it's true. Like, this is real. Sharp is very fortunate that we ran conservatively with healthy margins for a long time, decades, and we're able to reserve as a nonprofit those resources. And we measure it from a financial health perspective as what we call days cash on hand. And we need that. That's operational flexibility in your household budget. That's your savings account. Okay. And the only way we were able to keep services provided to patients with that mismatch of revenue to expense growth and operating at a deficit for last year is by spending off of the balance sheet, spending our savings. And the reality is that we finished the year with over 300. This isn't on record, so we're looking good for year end, but 300 plus days cash on hand is where we're headed. And we feel good about that, but we're very fortunate to have it. And many systems don't have that cushion. And so there are many hospitals that are trying to figure out how to make payroll. And that's where these cuts are hitting. And that scares me for the sake of our industry. And you'll see some consolidation, some new affiliations. We're working on an affiliation with the North County provider down in our service area called Tri-City. And I think that's very good and encouraging for the future of healthcare delivery in San Diego. But let's be real, like, that's not going to be an option for all hospitals. And unfortunately, I agree that hospitals are closed.
I guess I'll say all healthcare providers are at risk of closing. And I think there are, a range of organizations and institutions that are in different places financially. I think people, even organizations that might be doing semi-okay, won't be making investments that are needed otherwise for the population to receive healthcare services, because there's an abundance of uncertainty in what's happening and what could happen next. And people will ultimately, it sounds dramatic, but more people will die. I mean, we know from the Affordable Care Act experience that healthcare saves lives, people get coverage, they get care. We know from our own analysis, when you have people who have covered, they actually do utilize services more. That comes at some cost, yes, but ultimately they get the cancer screenings earlier. They're diagnosed with stage 1 cancers as opposed to stage 4 cancers. They get their blood pressure controlled so that they don't end up with a stroke in the emergency department or a heart attack, and then end up hospitalized in the ICU costing $1 million or millions of dollars. So we know care and coverage saves lives. We know it actually likely saves the system money. And it's just, we're not accounting for the full cost and also the human cost and we look at return on investment. What about value creation? What is the value of saving lives and, preventing death, preventing illness? I mean, public health folks like to talk about quality adjusted life years and trying to put some numeric value to such things. Those concepts haven't made it to the halls of Congress, I'll say.
Thank you. Let's not forget medical debt.
Yeah.
That's going to be also a consequence of losing coverage. So with all of we're talking about the uncertainty in implementing the legislation. We kind of can predict what are the outcomes. How do you communicate the uncertainty to your constituents, whether it's to your patients, to your staff, to your all of your stakeholders? Or do you?
Of course, I mean, it's in the news cycle. Like everyone knows about it and everyone's worried about it and everyone's anxious about it. What does this mean? I end up trying to communicate a persistence that we are here, we'll persevere, we will get through this, and some amount of urgency at the same time that we need to be focused on this. We need to make some changes now. So trying to use the benefit of some advance notice of what is going to happen, even when there is a fair bit of uncertainty on exactly the range of what could end up happening. We do know we need to make some changes now. And what I worry about is I hear a lot of peers not making changes now. They're sort of sitting flat-footed and like expecting something will fall out of the sky, as it frankly usually has. The federal government has bailed out, COVID felt like that moment actually at one point in time, 2019, 2020, when it was like, oh no, the sky's falling, literally. We're burning. I remember my CFO called me and said, Mitesh, we're burning this amount, millions of dollars per week. I said, oh, we're in trouble. But things changed. Money started flowing. COVID bailout money started coming through in various forms of all the different programs that you know about. But, I think the communication is key and important to ground people in the reality, to hopefully motivate people to making changes that need to be made now in advance of the changes happening, and trying to harness some creativity. So one of the ones that's on my mind really is the increased administrative burden on keeping people on coverage. Can we do something now to get people educated and get the patients, the community members knowledgeable of that? Can we use the technology that's in our pockets, mobile devices? Can we use AI to automate and remind people that are about to fall off of coverage so they don't lapse? I remember the days we were talking about uninsured single adults when you had a lot of those people on these wonky, not so great coverage programs that would cover them for 3 months, let alone 6 months, and they'd fall off of coverage and they'd stop taking their meds and they'd become dysregulated, out of control, diabetic, out of control blood pressure. I was a clinician at the time. And then they get coverage back and then they get back into control. So they go through these cycles, and we got to work on that now. Sorry, I digressed. So
Education. I think education is the most important thing. Contrary to what we all see on Instagram, most people really don't understand politics, elections, policy making. We don't understand how those things work because we don't learn them. I mean, I learned it through working in the industry for the last 15 plus years and working for elected officials, writing policy, passing policy, understanding how the process works. I haven't ever done as many presentations on what the policy process is as I have in the last 8 months. And I think that once people really understand what's happening, they can digest the information in a different way. And that's the approach we've really taken at Cedars-Sinai, communicating with our stakeholders internally, whether it's patients, staff, volunteers. We have to over communicate what's really happening so that folks don't run with the information that changes every 5 seconds.
And I would just mention that I think communication is everything, and education, given that we're at the Paul Torrens Health Forum and he was an educator in public health, founding member of the field, it's really critical we point out the role of education in health. Those folks who are less educated tend to be less healthy in the US. And so at times like this, we have to double down on our commitment to re-educating and staying out ahead of all of these policy changes to help people maintain their access. I think from a provider's standpoint, I think SHARP, one of the things I've been very impressed with since I joined the organization is how executive management is very much in front of the internal employees, the many stakeholders in the community through active campaigns effectively and it's very transparent, very back and forth, very open to face the challenges, to communicate what we're working with, because there's a huge amount of fear. We had our first layoff impacting 315 individuals in June of this year in more than 2 decades. And in total, we eliminated over 400 roles. Now we employ about 20,000 people. So as a percentage of staff, it's not enormous, but it's a lot of people's lives impacted. And the role that fear plays, that was sort of before HR1, June, right? And so folks are very insecure about their livelihood. So I think the more we communicate, we talk about not just the challenges, but what we're doing to address them. And then also, I think as a large provider organization, and CEDAR's, another example of a great voice in our industry to lobby and get in front of Washington and say, hey, listen, this is the real world impact of these changes, and we're doing our best, but you have to work with us here. So that's what I would share.
Thank you.
So we have some amazing questions and nowhere near enough time. We may have to do part B of this, but so I'm going to start with the most popular question. How can our health system step up to support our most vulnerable populations until we recommit to population health policy at the federal level?
I think we're already doing that, and we can continue to do it. Cedars-Sinai's community benefit program is huge. I mean, we spend about $1 billion a year to put back into the community in both health services, programming, and direct grant making to services organizations. We are the largest private funder, non-foundation private funder of housing and homelessness in LA County. And I think that those things are really important and don't get talked about enough. Hospitals are doing a lot of work, and community clinics do a lot of work to give back to the community to ensure that if somebody isn't walking into a community clinic to receive preventative care, that our Coach for Kids program is pulling up to a park to provide preventative care and health screenings at that park and meet people where they are. So I don't want to say that we're already doing everything we could possibly be doing, but we are going to continue our commitment to community service provision to ensure that these populations don't fall through the cracks in this really challenging time.
Oh, that's a tough, multifaceted question. My brain's going in 5 directions. I would say we're a grant recipient of Cedars, thank you, at Venice Family Clinic. I think when I think of this, the potential, we don't have a coordinated healthcare system, right? In the United States, we have 5 different systems in parallel. Maybe I'm undercounting, I don't know. I think there is some opportunity, and sometimes challenge creates opportunity for large healthcare providers to really partner closely with community health centers like ours in the next beyond community benefit, so actually direct provision of care. So I'll give you an example. I've contracted in my previous life with large providers to bring care to the clinic, and so that in a way it's a win-win-win. So instead of the patient going to the emergency department with hip pain, they can get an orthopedic consult in the clinic. The major partner, their role is to help make that deal happen, get the doctor to us, but we take the risk and we pay for those services at the clinic, and the patient gets the care ultimately at the end of the day. There are so many, there's possibilities I think we could imagine. Can we recreate a health coverage safety net in Los Angeles County specifically that was previously in existence through the County of Los Angeles? My Health LA, Healthy Way LA, you've heard of that. It's not being talked about really at the county level from every folks that were there. The county's like, we don't have money either. We're having massive federal government cuts. They're talking about, I think, $2 billion out of an $8 billion budget is what I've heard from them out of one place in public health at the county. So there's a lot of challenges in front of us. Everyone's budgets are being cut at this point in time. Everyone's facing challenges, and then we're all being asked to do more. So I think it's a tough one. I don't have a great answer for it, and I think we need to. Can we recreate a coverage approach that everyone feeds into? In a past life, this was before the ACA. I had local hospitals contributing to help open an ER because they were getting bombarded in the emergency department. Guess what? That's probably going to happen again. They helped us open an outpatient ambulatory community clinic and an urgent care site, which ended up becoming a primary care site I was the first doctor hired there. We ended up having 10,000 patients at that one site because there's so much demand in that community. So like these partnerships and actually really opening new modalities of care, like actual things, I think there's more opportunity to be had there.
I want to continue on this sort of opportunity theme. Maybe we'll get a little bit of uplift. But you know, we rarely experience moments when we have the ability to do fundamental change. What health reform would you recommend if we get to a post-Trump period?
Like viable health reform or just like my dream healthcare reform?
You can give us your dream if you also give us viable.
No, Tim, go.
I'll take it. So I will tell you that I am a free market capitalist at my core. I grew up as a banker and I never would have been a proponent for universal care coverage. Wouldn't, just doesn't. I would have thought it's an entitlement program. And then I started learning about public health at UCLA. And I started to realize that the costs to society for care, that when people don't consume care, don't have access to care for neglected conditions, and then they wind up coming and receiving that care at some point in the future. I think education is foundational. I think access to care is foundational, and it must be paid for. So I would, if I had a magic wand, I would find a means to develop, and you could be, it might be something that looks different than what we've envisioned universal care to look like in the past, because we have all different modalities of delivering care these days. But I would come up with a health education foundation and a basic universal care coverage for all that focuses on health, well-being, and preventative and diagnostic care. And I think if we did that at a societal level, it will lower costs probably a lot quicker than we realize, because we're hacking at this thing from all different angles, trying to solve a real problem. But is it really solving the problem, or are we kicking a can down the road? To me, it feels like we're kicking a can. But those are Tim Murphy's opinion.
No, you go.
I mean, I'm a single payer guy. I would just tell you that straight out. And there's ways of getting there. You can go the German way, which is private, and regulated, and like everyone drives a car, different brand of car, but it has seatbelts and has airbags and all that sort of stuff. That's sort of the German model, where you can say that everyone's using an HDMI port, which is single payer, right? So it's sort of like I would go with the single payer model. But look, I've thought about a lot of how do you get there. And I remember we've had many debates about this point. Is it in a Medicare expansion to lower the Medicare age? Or I actually have come around in my mind to thinking that Medicaid expansion is actually the way to go. How did we get here? Because we could step on people who don't have a voice. If you expanded Medicaid such that it went up to 200%, 300% of federal poverty level, or some number like that, or it was a safety net for people who didn't get coverage through employment, you'd get there. We'd get to full coverage pretty fast. So I think that's what I would say. I don't know if that's potentially practical if you did it over time. And
I think so with both of you on universal healthcare coverage. However, I really struggle with trusting the United States of America to handle universal coverage appropriately. I think that the unintended consequence that's really hard to solve for is figuring out how you don't create a larger gap between wealthy and low income. I think we're already seeing folks moving to concierge care models where if you can afford it, you pay for it. I have a doc that I've had for most of my life who is now in a concierge model, and it's like $10,000 a year just to see her once. And that's really challenging. And I think that in a universal model, we create that divide where folks who can afford it get really good concierge medicine coverage and die at lower rates than the people who have this universal coverage and can't afford anything else. So I really worry about what that model looks like and how we implement it. In my dream world, I think that we find a way for the federal government, local government, and state government to work together to approach healthcare. We talked a lot about the federal environment, but what we didn't talk about at all is the state of California and the way that the state of California really overregulates in the healthcare space. You mentioned consolidation a little bit, and when you said it, I was like, well, if the state will let you, hospitals are going to close, but somebody could maybe take that hospital on and provide the care still if the state would allow us to do that. So I think that there are a lot of challenges that we experience federal, state, and local. And if we could find a way to have healthcare policy be centralized, and nothing centralized between the three levels of government, but dream world, all three levels of government working together to address healthcare, as it is our biggest spending item in this country. I think that's probably what I would hope to see in the future.
I want to thank our panelists. This has been a phenomenal conversation. And I want to thank all of you for joining us. We appreciate you spending some time with us here, thinking about Medicaid and thinking about how we can manage and continue to deliver care in what is essentially chaos. Our next health forum is February 25th. I hope to see you there. Thank you.